Hi, this is Sarah Day. I am a registered nurse here at Hugh Chatham Memorial Hospital. I'm the post-acute coordinator with the Wave 1 team. Today I want to discuss the challenges and successes with implementation of the COMPASS model here at Hugh Chatham. This is just a brief introduction to our facility here. We have 81 inpatient beds, 24 emergency room beds. Usually in a year we see around 275 to 300 stroke or TIA discharges. Typically 65 to 70% of those are discharged home. And here in our area we have one outpatient neurology practice, and we have one physician at that practice and one PA. During the COMPASS launch, we faced some challenges. There's 4 listed here. Probably the biggest challenge was capturing eligible patients. During the first week, I think we actually missed 2 or 3 patients, and so we quickly learned that we needed to implement some things so that people would be reminded to contact me prior to the TIA and stroke patients going home, because, you know, this was a new intervention for us. So the first thing we did to our discharge order set was we added call post-acute coordinator prior to discharge. So when the hospital has discharged the stroke and TIA patients and they use their order set, this automatically comes up under the physician orders for the nurses to do. The next thing we did so that would take place was that we had to educate the managers on the units and the team leaders, both on the medical unit and the ICU. We also had to in the ED, because we found out that we were having some TIA patients discharged directly out of the emergency department. That's unusual. We typically hold them for 24 hours for observation, but for the ones that are discharged out of the ED, we had to educate the ED coordinators and team leaders in that department to contact me prior to discharge. Also, when we had our community meeting here at the hospital, we invited a case manager to join our meeting. So she's very engaged in this program and knows the importance of the COMPASS model. She's also here and calls me for the TIA and stroke patients if there are some on the floor that she thinks I need to probably look at. I also get a core measure report every morning, so that may include, you know, congestive heart failure patients and stuff like that too, but that's a pretty good way to capture stroke and TIA patients. I attend morning rounds. It's a multidisciplinary meeting among different specialties, physical therapy, nutrition, the physician. This is a good place for me to question the physician as to whether the discharge diagnosis is going to be TIA or stroke. It's also a good time. Our home health team is also represented there, and it's a good time for us to talk about whether the patient needs home health, physical therapy, or, you know, maybe they need outpatient treatment or something like that. There's also a pharmacist at the meeting, which is a good thing to discuss, you know, aspirin therapy and things like that they might need at discharge. The second challenge we faced was the 2-day follow-up phone call. We didn't have a whole lot of problem with this. The main thing we found was that it's really important to meet the patient in person, because that way you can verify that their number is correct. Often, you know, the stuff listed in our system may be years old and may not have been updated when the patient came in, and so that's an important aspect of that, the 2-day follow-up call. The third challenge was the 7 to 14-day clinic visit. Like I mentioned earlier, we only have one neurology clinic in our area. The PA at that clinic, Bill Jarrett, is actually our APP. So what we did to make sure that their schedule was available was he cleared his Tuesday and Wednesday afternoon after lunch. That way I could make sure I always had space to put COMPASS patients. They also gave me access to their schedule so that I can just go in and directly schedule the patients and not have to bother the office staff over there. I always schedule their appointments before they're discharged, put it on an appointment card for them, and talk to them about it before they leave to make sure it's something that they will be able to attend, that there's no conflicts in their schedule. I also call them, especially if it's, you know, if it's 3 or 4 days after discharge, we don't, but if it's, you know, a couple of weeks after discharge, we call 1 to 2 days before to remind them that they have an appointment Sometimes I do this, and sometimes some of the office staff over there does because that's just what they do. That's just part of their routine is they call patients to remind them of their appointments. The other thing, we schedule patients as soon as possible after hospitalization. So usually it will be within 4 or 5 days of discharge. This is helpful if the patient needs to reschedule because a lot of times you can still get them in within 14 days. We've had this happen a couple of times. They were scheduled 5 days out and needed to cancel, but we were still able to get them in within 2 weeks of discharge. And then again, discussing with the patient in person the importance of follow-up is very important. Another challenge that we faced in the beginning was backup PAC and APP. For myself, we have 2 people that are my backup, the stroke and education coordinator and the director of healthcare improvement. Both backed me up if needed, and they did go to the Compass boot camp so that they could be familiar with the process. We do not have a backup APP, but our APP is very good to arrange his schedule for availability for me. You know, he went on vacation actually a few weeks ago, but still managed to see all the patients that we needed to meet the 14-day mark. This is just a comparison of the enrollment process as far as weekday compared to weekend. So during the weekday, as I mentioned earlier, I receive a core measure report every morning that has the stroke and TIA patients on there. I usually look over these charts and then go to multidisciplinary rounds. That way I can discuss again with the physician, is this somebody that's possibly a TIA, whatever they need, you know, as far as therapy and outpatient treatment and those kind of things. I then visit the patient prior to them going home, give them their folder, schedule their appointment, explain the importance of Compass, get a telephone number, and then I also tell them when to expect a call from me. So if they go home on Wednesday, I usually say, I'm going to call you Friday. It will probably be Friday morning. Are you going to be available? And that also helps for them to know when you're going to call them. The weekend's a little bit different because I'm not here. I do still receive the core measure report at home, or I receive it via email so I can see it at home, or Monday morning when I come in. And this way I can call the patient on Monday that have been discharged over the weekend and can enroll them over the phone. We also have a really good weekend case manager, and she emails me every Sunday afternoon to let me know if there's been any stroke or TIA patients discharged over the weekend. So on Mondays, when I return to the office, I review the record, I call the patient, enroll them over the phone, then I mail them their folder. I also make their follow-up appointments while we're on the phone so that they know when it is, and I send them an appointment card in the mail. These are just some tips for enrollment success. Again, the face-to-face encounter is so important because the compliance is just better. You can get the phone number, you can tell them when you're going to call, you can find out when is the best time for them to come to clinic. And I think a lot of times just putting a face to a name, you know, it's just easier to make that connection in person rather than on the telephone. Another thing I think has been very important for us and something that's worked really well is involving a case manager as part of our core Compass team. The case management team here is awesome. They're the ones that set up home health, PT, nutrition services, that kind of thing. And so having them come to me and let me know what patients need has been very helpful. To improve enrollment, information gathering, verify phone number, we talked about that. I also wanted to mention our NIH stroke scale. That is part of our stroke and TIA policy and admission order set criteria. I know that's a question when you're enrolling patients is what their NIH stroke scale score was, and that's been very helpful to us is that that's a policy that you get that on admission and at discharge. Tips for 7 to 14-day clinic visits. One thing that's helped us with compliance in clinic is definitely calling the patients 24 to 48 hours prior to their appointment just to remind them to come. Also, when we do this, we find out if they can't come or maybe, you know, they've forgotten and they need to reschedule. We can also do that at that time. Again, we try to schedule them within 7 days, so if the appointment needs to be rescheduled, we can still get it within 14 days. And then we have the dedicated clinic time that are only for Compass patients. One thing we found out in the beginning with that was, when the patients weren't showing up, then our ACP was concerned because he didn't have patients that afternoon. So we have started overscheduling a little bit and putting 1 or 2 patients. Typically we start at 1 o'clock, so we'll put 1 or 2 follow-up patients at 1 o'clock. So while I'm in with the first Compass patient, he still has a couple of patients to see. Also, while I'm in the room with them at the office visit, I go ahead and obtain the consent form, explain that to them, and get that while I'm in case they leave prior to me seeing them again. Tips for the 30 to 60-day phone call. I usually remind the patient at clinic when I'm going to call them again. So if it was, 14 days out, I'd say, hey, I'm going to call you again in 2 weeks. And then while we're on the phone for the 30-day call, I always remind them, I'm going to call you in another month. That's when you'll hear from me again. And thank you. There's my email. Please feel free to email me with any questions that you may have. It's shday@hughchatham.org.